Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, I am delighted to have you join me today for a very important and often under-recognized topic in clinical practice. Disorders of gut-brain interaction or DGBIs. As general practitioners and frontline doctors, you see patients every day who complain of chronic abdominal discomfort, bloating, constipation, or unexplained digestive symptoms. Yet, their investigations come back completely normal. This lecture will help you understand what DGBIs really are, how they affect your patients, and most importantly, how you can recognize and manage them more effectively without unnecessary medications or endless referrals. We shall talk about the gut-brain connection, the biopsychosocial model, and why your role as GPs is central in improving outcomes for these patients. Let's begin our journey into the fascinating world of DGBIs and learn how to care better, think deeper, and treat smarter. Bismillahirrahmanirrahim. Today, we are addressing a group of GI disorders that are extremely common in practice, yet frequently misunderstood. Disorders of gut-brain interaction or DGBIs. You may know them better by their former name, functional GI disorders. But we now understand them differently thanks to research into the gut-brain axis. Today, I shall explain what DGBIs are, how they affect your patients, and why you as GPs must take them seriously. By the end of this session, you will understand what DGBIs are and how the gut-brain axis plays a role. How common they are in Pakistan and how they impact patients' quality of life. Why these disorders are frequently misdiagnosed or mistreated, and what GPs can do differently. What are DGBIs? Let's begin with the basics. DGBIs are chronic gastrointestinal disorders with no clear structural or biochemical abnormalities, previously known as functional GI disorders. They result from a dysregulation of the bidirectional communication between the gut and the brain, and what we call the gut-brain axis now. Concepts of the gut-brain axis. The gut-brain axis is a bidirectional communication network between the gut and the central nervous system. Both these organs affect one another via neural, endocrine, and immune pathways. This axis regulates stress responses, emotions, and even neurological disorders. When this axis is disturbed, it leads to altered gut motility, visceral hypersensitivity, immune activation, and stress-related symptoms. The gut microbiota plays a crucial role in the gut-brain axis by producing neurotransmitters like serotonin and dopamine, which influence mood, cognition, and mental health. Research suggests that imbalance in the gut microbiota may contribute to conditions such as anxiety, depression, and neurodegenerative diseases. Therefore, factors like diet, probiotics, and lifestyle can impact gut-brain interactions. Gut-derived neurotransmitters. Different bacteria in the gut produce different neurotransmitters which play vital role in the gut-brain interaction. These include serotonin, gamma-aminobutyric acid, dopamine, acetylcholine, norepinephrine and epinephrine, and histamine. So let's understand these one by one. First, we understand the serotonin. The gut contribution to serotonin is that approximately 90% of the body's serotonin is produced in the gut by enterochromaffin cells, which is influenced by gut bacteria like lactobacillus and bifidobacterium. Functions of serotonin in the brain is that it regulates mood, emotion, and cognition. And if there is low serotonin levels, these are associated with depression and anxiety. Now, a few words about the gamma aminobutyric acid. The gut contribution, certain bacteria like lactobacillus and bifidobacterium produce GABA, the brain's primary inhibitory neurotransmitter. Functions of the GABA in the brain is that it reduces stress and anxiety by calming neuronal activity. And when we think about its disorder, the dysregulation of GABA is linked to disorders like generalized anxiety disorder and depression. Now, a few words about the dopamine. The gut contribution, gut microbes synthesize dopamine precursors like tyrosine and phenylalanine. Dopamine controls reward, motivation, and motor functions in the brain. And imbalances of dopamine are linked to Parkinson's disease, addiction, and depression. Now let's understand the role of acetylcholine. Some gut microbes can produce acetylcholine, which is a neurotransmitter essential for memory, learning, and attention. So as said, it's a key neurotransmitter and it is associated with memory and learning, attention and focus, arousal and wakefulness, and motor control of the body. So deficiency of acetylcholine is associated with Alzheimer's disease and cognitive decline. Now, the norepinephrine and epinephrine, the gut contribution is that gut microbes such as Escherichia coli and Bacillus species produce these catecholamines. They regulate alertness, arousal, and the fight or flight response. An imbalance in norepinephrine and epinephrine are linked to stress-related disorders. And lastly, the histamine. Certain gut bacteria like Lactobacillus reuteri produce histamine. It regulates sleep, wake cycles, appetite, and attention. And when there's a disorder of histamine, it leads to poor sleep, appetite, and poor attention. So, common examples of DGIs include irritable bowel syndrome with its subtypes like diarrhea predominant IBS, constipation predominant IBS, and mixed pattern of IBS. Then functional dyspepsia, in which patient presents with fullness, bloating, and early satiety. And of course, functional constipation and or functional diarrhea. And lastly, the functional abdominal pain syndrome. These patients present with long histories of symptoms, but investigations often reveal no organic cause, which leads to frustration both for the doctor and the patient. They are labeled as anxious or imagining it. There's a clear-cut Rome 4 criteria for disorders of the gut-brain interaction, and they've divided these into esophageal disorders, gastroduodenal disorders, bowel disorders, anorectal disorders, gallbladder and sphincter of Oddi disorders, and centrally mediated disorders of the abdominal pain. What about the prevalence of DGBIs in the world? A global epidemiological study of functional GI disorders was conducted, and 73,000 adults were surveyed in 33 countries of the six subcontinents. The data was collected by internet in the 24 countries, and these are shown blue here. Then by household interviews in the 7 countries, which are shown here as yellow. And both methods, it means by the survey and household methods, the surveys by in China and Turkey, and these are shown green. Prevalence of meeting criteria for at least one of the 22 functional GI disorders, which I shared with you here. All participants on the internet survey, they showed 42%, rather 43%, they were having at least one of the these 22 functional GI disorders, and in household surveys, 21%. And out of these 42%, when we see the gender-wise, 49% of the females and 36.6% of the males on the internet surveys, they met the criteria for at least one of the 22 functional GI disorders, or the DGBIs. And on the household surveys, out of 21.6%, when we divide them into females and males, 24.1% were females and 19% were males. It means the DGBIs are more common in female as compared to male. This is very interesting. The whole world, the prevalence of the DGBIs, the outer ring of the DGBI, only DGBIs, this is the only DGBIs, the outer ring, and the inner ring is the IBS in different countries. So the different countries, and this is the DGBI, and this is purely the inner ring is the purely the IBS. What about Pakistan? Although precise data for Pakistan is limited, global and regional studies suggest that 10 to 20% of adults may suffer from some form of DGBI, especially younger adults and women. Impact of DGBI on quality of life. These are net minor disorders. Patients often miss work or school because of the DGBIs. They may make frequent healthcare visits. They undergo unnecessary investigations. And many of them develop coexisting anxiety or depression. Think of a young female who comes to you every few weeks with abdominal bloating, discomfort, alternating constipation and diarrhea, all tests normal. She is anxious, tired, and does not feel heard. Such patients lose productivity, develop mental health issues, and feel stigmatized. We must recognize the hidden toll DGBIs take on their social and emotional well-being. Why are DGBIs misdiagnosed or mistreated? Now let's ask the critical question. Different reasons. Reason number one, focus on structural disease only. Second reason, lack of awareness about gut-brain axis among physicians. The third reason is that why these are misdiagnosed and mistreated. The psychosocial symptoms are dismissed or overlooked. And the fourth reason, no visible findings on tests. And this leads to mislabeling patients as functional in a dismissive way. So to sum up, as clinicians, we are trained to find structural and biochemical causes. But DGBIs do not show abnormalities on standard tests. So they get labeled non-organic or functional in a dismissive way. So as a result, what we see in our prescriptions, overuse of PPIs, laxatives, and antispasmodics. Prescribing antibiotics like rifaximin without proper diagnosis. Repeated imaging and endoscopy are done despite normal findings. And patients are told nothing is wrong, which worsens their distress. But remember, these are real disorders with real mechanisms. The dysfunction lies in the gut-brain signaling, not in tissue damage. What we need is a positive diagnosis based on clinical criteria and patient's history, rather than a diagnosis of exclusion. You, as general practitioners, play a central role here. You are the first point of contact. You can make or break their care experience. Every recognition can save the patients from years of unnecessary testing and ineffective treatments. You can establish a therapeutic alliance by validating the patient's symptoms, offering structured treatment plans, and incorporating psychosocial care. When you recognize a DGBI, name it and explain it, you validate the patient's suffering that build trust. You can reduce the burden on gastroenterology services by managing these cases at the primary care level. With confidence, you can prevent over-referrals, reduce healthcare costs, and provide truly holistic care by addressing stress, sleep, and lifestyle. You do not need a GI specialist for every case. You need to feel confident in recognizing and managing them. Think of this as managing a chronic condition like diabetes. Symptoms fluctuate. Patient's education matters, and reassurance is key. DGBIs require a biopsychosocial approach, and GPs are ideally positioned to deliver this kind of holistic care. Building trust and long-term therapeutic relationships is only possible through you. To wrap up, DGBIs are real, common, but under-recognized and distressing and debilitating for patients. They stem from gut-brain axis dysfunction and require a biopsychosocial approach, not just pills and tests. Their diagnosis lies in recognizing the gut-brain connection, not just chasing lab values. GPs can make a transformative difference with empathy, education, and a confident diagnosis. So, dear colleagues, disorders of gut-brain interaction represent a significant yet often under-recognized burden in clinical practice, particularly in primary care settings. Today, we have reviewed the pathophysiology, clinical relevance, and diagnostic challenges of these conditions, as well as the critical role of the gut-brain axis. We have also emphasized the importance of making a positive clinical diagnosis rather than relying on exclusion and adopting a biopsychosocial management approach. As primary care physicians, your role is pivotal. Early recognition, empathetic communication, and evidence-based patient-centered care can dramatically reduce unnecessary investigations, enhance patient satisfaction, and improve outcomes. Thank you for your participation in this educational activity. I encourage you to reflect on how today's learning can be integrated into your everyday clinical practice and continue engaging in lifelong learning to better serve your patients. Dear colleagues, thank you for staying with me through this important discussion. As we have seen, disorders of gut-brain interaction are not just vague or imaginary problems. They are real, complex, and deeply impactful conditions rooted in the gut-brain axis. As general practitioners, you hold the power to make a genuine difference in these patients' lives, not by doing more tests, but by listening better, understanding deeper, and applying a biopsychosocial approach. Remember, a confident diagnosis, empathetic communication, and appropriate reassurance can often be more powerful than a prescription. Let's continue to evolve our practice from disease-centered to patient-centered care. Thank you once again. Stay curious, stay compassionate, and keep learning. Khuda Hafiz.